right, well, good morning, and I'd like to thank Dr. Verstovsek and the organizing committee for the opportunity to talk here today. So we're going to talk about the MPNs that transformed AML and the clinical factors, genetics, and the biology behind that transformation. So as you all know, the myeloproliferative neoplasms are clonal hematopoietic disorders which have clinical consequences, most often of hemorrhage or of thrombosis. But the most feared consequences by physicians and patients is transformation to acute leukemia. So what's the natural history of transformation to acute leukemia? Well, the estimated risk of leukemic transformation at 100 months from diagnosis for patients with ET is about 4%, for PV patients about 8.7%, and for MF patients almost 20%. So certainly not a trivial risk of transformation. Transformation carries a very poor prognosis in general. In data from Aruba Mesa and colleagues from a number of years ago, the median survival that was found in patients who transform was approximately 2.7 months. More recently, a paper that actually just came out last week from a Danish cohort study demonstrated that patients with post-MPN AMLs have, again, a very poor prognosis, but strikingly, if you look at patients who have treatment-related AMLs or AMLs arriving from MDSs, the prognosis still appears to be quite worse than those diseases. The poor prognosis, we think, in large part is mitigated by the fact that these diseases are largely resistant to standard anti-leukemic therapy. So in comparison to patients who received induction chemotherapy versus those who didn't, the increase in survival was from 2.1 months to 3.9 months. And in those who received treatment versus those who received supportive care only, the increase was 2.1 months to 3.3 months. Again, from this Danish study that came out recently, if you look at patients with de novo AML who are in the green bars versus those who have secondary AMLs largely from MPN in the red, you see that despite different types of therapy, if we look at supportive care versus low-intensity therapy versus those who receive high-intensity therapy, the outcome for patients with secondary AML from MPN is particularly bad. So that being said, there is a need, obviously, for better characterization of the biologic and genetic processes that drive leukemic transformation from chronic phase MPN to AML. There's a need to develop genetically accurate models of leukemic transformation such that we can model new therapeutic strategies in this disease. So what are some of the clinical risk factors for leukemic transformation? Well, a number of different studies have identified clinical factors that have certainly correlated. For example, in patients with ET, there is an association with the development of anemia or with platelet counts greater than 1 million. In patients with PV, there is an association with age greater than 70, as well as a number of therapeutics, which we'll talk about in a moment. In myelofibrosis, there's a number of risk factors that have been identified, including age greater than 70, peripheral blasts greater than 3%, bone marrow blasts greater than 10%, or a high-risk karyotype, high-risk per AML literature, splenectomy, which is a little bit of a controversial topic in this regard, and a monosomal karyotype. So what about therapy? What is the impact of therapy potentially on the development of leukemia? Well, a number of studies in aggregate have determined that agents such as busulfan or pipabroman or P32, none of which are frequently used at this point, certainly are associated with a marked increase in the hazard ratio of the development of leukemia. Other data has indicated that there is some increase risk with the use of erythropoietin-stimulating agents, or danazol. The role of hydrea is, I think, largely remains controversial, but in this particular data series, there was no association noted. What about the genetic risk factors? So an important paper from Vanucci and colleagues looking at patients with primary myelofibrosis determined that there were several genes that were strongly associated with a risk of chronic phase transforming to acute leukemia. And these include the splicing factor SRSF2 and the epigenetic modifiers EZH2, ASXL1, and IDH1 and 2, which we've heard a bit about this morning. Now, taking the driver mutations by themselves, JAK2, MPL, and calreticulin, do these have an influence in one particular regard? The answer seems to be largely not, that despite whatever the driver mutation is, if we consider it as a single entity, that doesn't seem to impact the risk of transformation. However, we have about 10% of patients or so who we deem to be quote-unquote triple negative. These are patients who don't have any of the 3 identifiable driver mutations. And these patients have an enhanced risk of leukemic transformation, which is quite statistically significant. Now, in this regard, when we talk about genetics and the risk of transformation, one really, I think, important point to consider is that mutational profile of a patient is not static. So in data from Lundberg and colleagues that was published last year, the group looked at samples of patients over a couple of periods of time and did clonal assays in mutational profiling to look at the evolution that we've sort of talked about a little bit this morning. And in many cases, if we take this case here, for example, a patient had acquired a calreticulin mutation, subsequently followed by an ASXL1 mutation, and then ultimately by an EZH2 mutation. And another example, a patient with a calreticulin mutation subsequently went on to develop TET2 mutations. So we have to think about this in a dynamic manner, and that sort of leads to the question, should we be testing people at serial time points, and should we be testing people for more than just JAK2, MPL, and calreticulin? I think that's an open question, because on the pro side, there is more potential information about prognosis, certainly. There is the potential to identify new targets that might be amenable to therapeutic intervention. And then there's an opportunity to learn more about a patient's individual disease. On the other side of things, though, it's unlikely to change management for most patients. If, for example, we find a patient who has a JAK2 and an ASXL1 mutation who presents with new myelofibrosis, how would we change our management? Are we going to transplant the patient? Are we going to start therapy? I would argue that there's no data to guide that decision. The second is that it might be quite expensive. There are a number of commercial laboratories engaged in testing, and these tests are often covered by insurance, but not always. And finally, it might be anxiety-provoking. Again, we take the example of the patient who has the ASXL1 mutation. What are we going to do about that that's going to change management, and how is that going to affect the patient and how they perceive their disease? So how does transformation actually occur? Well, I think a number of people have argued that it's the accumulation of additional genetic events over time that subsequently lead to transformation and also to disease progression over time in myelofibrosis, for example, with extramedullary hematopoiesis. So we know that a number of mutations can predispose to the MPN driver mutations, as has been talked about this morning, but that patients can acquire other mutations subsequent to the main driver mutations over time. Now, in an effort to examine this more closely, we undertook mutational profiling of 33 patients who had transformed to AML, and this was undertaken as a collaborative effort between Foundation Medicine, Memorial Sloan Kettering, and the MD Anderson Cancer Center. And we used a DNA sequencing that used 374 targets, as well as some RNA sequencing looking at 272 genes that are frequently rearranged in a variety of malignancies. So the data from this demonstrated that the most frequent mutations at the time of transformation included JAK2 itself, ASXL1, IDH2, P53, calreticulin, and a host of other mutations. In terms of structural variations and copy number alterations, it was interesting that we also found changes in MLL, in terms of MLL rearrangements, as well as overexpression of MYC in a certain number of cases. The bottom line, or the takeaway from this, is that there is quite a bit of heterogeneity in terms of the mutational profiles that we see at the time of transformation. Now, one of the things that you will note from the last slide, if we go back for a moment, the mutations that we typically associate with AML are not the mutations that we frequently see in this cohort of patients. So, for example, we know that FLT3 mutations are among the most common mutations that we see in de novo AML. And so if we look at the mutational profile of patients from a large set of AMLs, de novo AMLs, from the ECOG 1900 cohort, these are Circos diagrams where the arc length represents the frequency of mutation. Here we see that FLT3 mutations are very frequent. But if we look at the cohort of secondary AMLs from MPNs, it's really quite minuscule. And the same thing is true for DNMT3A mutations, which again are quite common in de novo AML, but really quite infrequent in secondary AMLs. And so collectively, this data argues that secondary AML from MPN is a genetically distinct disease from de novo AML, and I think that also makes the argument that we need to think therapeutically about this in a different manner. So interestingly, we know that not all patients have a JAK2 mutation at the time of transformation. In those patients who we did not observe a JAK2 mutation during transformation, what did emerge were mutations in RAS, in both in NRAS and KRAS, which appeared to be quite frequent in the JAK2 negative population. But in the patients who did have the JAK2 mutation at the time of transformation, we actually didn't detect any NRAS mutations, which may implicate the RAS pathway as a mitigator of disease. Looking at this cohort a little bit more carefully and the co-occurring mutations that we see with the main drivers, one of the observations we made was that the JAK2 mutations were mutually exclusive of calreticulin mutations, which is consistent with observations in chronic phase disease. But another important point is that the co-occurring mutations between the different drivers appear to be different. For example, frequent mutations were seen between JAK2, P53, or JAK2 and IDH2. But with calreticulin, common co-occurring mutations were SRSF2 and NRAS, in fact. And with MPL mutations, IDH1. And so it may very well be that there are multiple co-occurring mutations that can occur in the given context of a driver mutation. What is the impact of these mutations on patient outcomes? Well, patients who have JAK2 or calreticulin or who are quote-unquote triple negative at the time of transformation appear to all have about the same survival, which again remains poor. But patients with SRSF2 mutations have a particularly poor prognosis as compared to those who are wild type for SRSF2 at the time of transformation. So this is an enhanced poor prognosis. Interestingly, though, if we look at other mutations that we know put patients at risk for transformation, those mutations don't seem to have an impact on overall outcomes. So, for example, ASXL1 mutations don't worsen the prognosis of such patients. And also the cytogenetics, if we look at the risk profiles as based on the AML literature, there isn't an apparent worsening of outcome with a higher risk cytogenetic profile. Now, a number of groups have demonstrated that P53 mutations occur more often at the time of transformation. One paper by Kralovics and colleagues had demonstrated that in chronic phase, approximately 3% of patients have a P53 mutation, whereas at the time of transformation, that jumps to 27%. So in an effort to look at changes in the variant allele burden or the percentage of the clonal driver, we examined JAK2, ASXL1, and a number of other frequent mutations that we had described, as well as P53, both at the chronic phase in orange and at the time of leukemic transformation in red. And when we look at the JAK2 mutant allele burden, we find that there is a substantial increase in that burden at the time of leukemic transformation. The second most marked finding was that the P53 mutations, in fact, significantly increased in terms of the overall allele burden at the time of transformation. Whereas other mutations that we know are prognostically adverse in terms of risk of transformation, such as ASXL1 and IDH2, didn't actually have a marked change in the variant allele burden. Looking at this on a patient level, this is an individual patient for whom we had chronic phase and leukemic phase disease samples. If we look carefully at the p53 mutant allele burden, it rises quite dramatically at the time of transformation and really coincides with the blast count, which went to 70% at diagnosis, whereas the IDH2 mutant allele burden in this patient only rose marginally. So, using the genetic data that we've just talked about, we then sought to use this to build a model of leukemia transformation in order to understand the biology better, but also to use this to model new therapeutics. And the way we approached this was to use a p53 null mutant mouse, or as a control, a wild-type mouse, from which bone marrow was extracted and then was infected retrovirally with a JAK2 V617F allele. This was then transplanted into a lethally irradiated chongenic mouse. When we did this, what we found was that the mice who received JAK2 and had p53 loss had a significantly impaired survival when compared to the control mice. There was a marked leukocytosis that was noted as well in the p53 null JAK2 mutant mice. And when we looked at organomegaly in these mice, both spleen and liver weights, there was a marked increase in the size of both the spleen and the liver in the mice bearing the loss of p53 with JAK2 mutations. And this is a representative example of the spleens in these various mice. Examination of the peripheral blood from the double mutant mice demonstrated the presence of large circulating blasts, and the bone marrow cytology demonstrated large clusters of blasts consistent with acute myeloid leukemia. Now, using blasts derived from these animals, what we sought to next do was to test various therapeutic strategies in vitro. So these cells were plated into a semi-solid media and then exposed to different concentrations of various anti-leukemic and anti-MPN therapies. So we first began by testing a couple of JAK inhibitors, and there is clinical literature supporting the idea that JAK inhibitors as a single agent can induce remission in some patients with AML. So we tested ruxolitinib initially and found that there was a dose-dependent decrease in the colonies that were formed with exposure to increasing doses of the drug. The same was true of the Cytopia 387 drug, where we saw a dose-dependent decrease. We then looked at PUH71, which is a heat shock 90 protein inhibitor. The rationale for looking at this was that literature from Marubiashi and colleagues has demonstrated that the JAK2 protein is a client of the heat shock protein 90, and thus inhibiting the heat shock 90 protein leads to degradation of JAK2. And so, again, with this strategy, we found a dose-dependent decrease in the colony formation from leukemia cells, but notably this occurred at much lower concentrations than we saw with some of the other drugs. And we also tested the smoothened pathway inhibitor LDE225, again with a similar dose-dependent decrease in colony formation. So there is clinical literature also to support the use of hypomethylating agents in patients with transformed disease, both azacitidine and decitabine. And in concurrence with those findings, the cells from the mice also had a decrease in the colony formation ability with exposure to increasing doses of decitabine. We then used the combination of decitabine plus ruxolitinib and did indeed find that there was synergistic activity if we compare this dose of decitabine to the combination of decitabine and ruxolitinib. And this has actually given rise to a clinical trial with which Dr. Mascarenhas will be talking about later this afternoon. Finally, we sought to do in vivo testing of different drug strategies. And based on the in vitro data that we had obtained, we used a strategy using a placebo versus the PUH71, that the heat shock 90 protein inhibitor, versus ruxolitinib as a single agent. So in mice treated, these are mice who were transplanted with leukemia, who were treated with any of these strategies. What we found was that the mice who received either ruxolitinib or who received PUH71 had a significant prolongation in their survival. When comparing PUH71 to ruxolitinib directly, that was also significantly, there was a significant increase in survival in the PUH71 treated mice. Looking at organ weights, both drugs were able to significantly reduce organomegaly in these mice. And finally, looking at the bone marrow cytology, we see that in mice treated with placebo, the marrow is largely consistent of blasts. In mice treated with ruxolitinib, we do start to see some evidence of maturation in the marrow. And with treatment with the PUH71, we start to see mature granulocytes as well as some remaining blasts, but clearly some more evidence of maturation. So the last point I'll make is that it's clear that from the genetics and now from in vivo biology experiments, we see that JAK2 and p53 can clearly contribute to produce leukemia in patients. But it's important that we keep in mind that a substantial number of patients who have a JAK2 mutation at the time of chronic phase disease lose that mutation in the leukemic phase. So if we look at paired patients, each designated by a row, we see that a certain proportion who were JAK2 positive lose that mutation. And what this tells us is that there is likely more than one route to leukemic transformation. And I think that the model that we're left with, that was published by Beer and colleagues a number of years ago, is that there are probably or likely founder clones that can acquire additional mutations and go on to develop leukemia, but there are also likely other founder clones that don't acquire the JAK2 mutation and acquire other mutations that drive AML. And this is an area that is under active investigation. So to conclude, we know that several clinical factors are associated with the risk of leukemic transformation. We know that mutations in ASXL1, EZH2, IDH1 and 2, and SRSF2 are associated with an increased risk of leukemic transformation. The role of serial mutational analysis in patients at this point, I would say, is unclear, but warrants further investigation. Genomic studies have revealed that the mutational spectrum of post-MPN AML differs markedly from that of de novo AML, and I think that is an important therapeutic consideration moving forward. JAK2 mutations plus p53 mutations are a common combination that lead to transformation, and that the model that we've described can be used to credential new therapeutic strategies. And finally, other pathways to transformation are being investigated, and I think will have a bearing on how we create trials for this disease. Thank you very much.